Hello, everyone. We're happy to have you for our session, The Heart of Care, Supporting Dialysis Staff for Enhancing Resilience. We have a very distinguished panel here today. The first is Dr. Bernard Jarr. He's a nephrologist in the Division of Nephrology at Johns Hopkins School of Medicine with joint appointment in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. We also have Dr. Kristen E. Rugbu, and she is a PhD MSRN, and she's a T32 postdoc fellow at the University of Pennsylvania School of Nursing in the Center for Health Outcomes and Policy Research. And we have also Danny Concepcion, who's been a dialysis practitioner since 1975, and he's experienced in clinical, technological, research, and administrative areas of dialysis. We also have Dr. Laura Plantinga. She's an associate professor in the divisions of rheumatology and nephrology at the University of California, San Francisco. We also have Dr. Lynn Oler, who is a nutrition services manager with Satellite Healthcare. And we also have Megan Urbanski, who's an assistant professor in the Department of Surgery, Division of Transplantation at Emory University, Dr. Megan Urbanski. So we're so happy to have you all today. And Dr. Plantinga, I'll let you get started.
Okay, so the original idea was I was going to give a short talk, and then we had some poll questions to get things going, but I think we will skip the polls and just start talking. But I will give a very short talk to get us started on the idea of what resilience is. So this is the name of everybody on our esteemed panel. I'm not going to ask you to do this when there's only two of you. No disclosures. Learning objectives. So we want to define the term resilience and explain its importance. Understand the associations between resilience and work outcomes, and identify personal and organizational factors in the dialysis setting that may be barriers or facilitators to worker resilience. So to start, defining the term resilience and explaining its importance. So I kind of divided this into what it is and what it is not. So resilience is a process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. So kind of in simpler terms, it's bouncing back from things that have happened. And this can be in your life or in work. It is determined by kind of your individual worldviews and how you engage with the world, the availability and quality of the support and resources that you have, and your coping strategies. What it is not, it's not a static state or a fixed personality trait. You're not resilient or not. It depends on the situation and what you've been through. It's not putting up with it or toughing it out. It's not like, I'm just going to power through this. And it's not a lack of need for or not seeking support. So why is it important? It allows people to manage and remain productive during crises. And it contributes to your personal growth and learning. It actually improves your leadership skills, and it helps people maintain well-being, so obviously, during periods of adversity. In the setting of healthcare, it's actually an effective means of mitigating or preventing what we call compassion fatigue, which is part of burnout. Okay, so understanding the association between resilience and work outcomes. Generally in healthcare, it's been associated with many, many things. One of them is nurse manager retention, better medication administration safety, so kind of on the patient side, it's safer. A lower prevalence of compassion fatigue among mental health nurses, and better work-life balance among healthcare workers, and many other outcomes. And I say less is known about resilience in dialysis workers. I would say almost zero is known about resilience in dialysis workers. So that's kind of why I'm presenting other settings. So what I'm going to present are data that aren't exactly about resilience because this is what we have. So burnout is something that can happen with a lack of resilience. And some of our work looked at burnout among nephrologists. And this was actually an NKF Education Committee survey. We had 457 respondents, and this was their age and sex distribution, and it was overrepresented in academic practice. And they used the 2-item mass lock burnout inventory, the MBI, and about 23% reported burnout. Now, this was 2019, so prior to COVID pandemic. And then that work actually led us to look among dialysis PCTs, and I apologize, Danny, for using that term. But so for that, we leveraged a partnership with NANT to survey U.S. dialysis PCTs about their perceptions of professional fulfillment, experiences of burnout, and turnover intention, so whether they plan to stay in their job. Cross-sectional survey was conducted in 2022, so during post crisis of COVID, but still during COVID, and included 228 NANT members. And we used the Stanford Professional Fulfillment Index, which is another measure of burnout, but also gets at kind of positive professional fulfillment. So we found that median professional fulfillment score, so it's on a scale of 0 to 4, where in this case it's from not true at all to completely true. We found a median of 2.0 for I feel happy at work and I feel worthwhile at work, and higher for my work is satisfying, meaningful, and I'm contributing professionally. Scores of 3 or greater indicate professional fulfillment, and only 37.3% had scores at that level. When we looked at work exhaustion, which is one aspect of burnout, we see from 0, not at all, to 4, extremely. We have a 2.0 for a sense of dread when I think about all the work I have to do, 3.0 for physically exhausted at work, and lacking in enthusiasm at work at 2.0. And then interpersonal disengagement, so this gets at kind of the compassion fatigue part of it. So we actually see much lower scores here from not at all to extremely. So fewer people are saying I'm less empathetic with my patients, with colleagues, less sensitive, less interested in talking, etc. 0 for less connected with my patients. So when we combine those two, which you do to get burnout, about 58% had what we would consider burnout at scores of 1.33. And that was primarily driven by the work exhaustion scores and less so with the interpersonal disengagement. And then when we look at turnover intention, we see about 36% plan to be working at the same facility in 3 years, 16% working at a different facility, and then 47% did not plan to be working as a dialysis technician in 3 years. Some of these may be training to become a nurse. They may be kind of moving up. We didn't ask that, unfortunately, but some may just be moving to an entirely different field. So even among, we figured people who were members of NANT would be relatively engaged with this career. Even among this group, the turnover intention was quite high. And of course, this is all during a PCT staffing crisis that continues. And then this is from one of the focus groups that we did, where we talked to staff and patients. And just from the patient's point of view, they do notice these things. So they've seen 2 types of relationships, one where they're being micromanaged, it was very stressful. You could see they were nervous and frustrated and afraid they were going to make a mistake. And then on the other side, they've seen, staff members who engage with one another. They're happy, asking each other how they need help. So much happier environment. And they say, I think that rubs off on the patients as well. So, kind of the third piece, personal and organizational factors in the dialysis setting that may be barriers or facilitators to resilience. So when we think about personal factors, so workers who are resilient, they tend to recognize their stress. So they recognize when something's going on, and this is beyond the usual. They're aware of the effects of stress on their body. They feel the shoulders, the blood pressure, all of that, and they're able to regulate their emotions. So kind of things you can try for this are, mind-body techniques, meditation, yoga, and then cognitive behavioral therapy is also another method for regulating emotions. Seeking support. So like I said earlier, it's not about not needing help. So identifying that you need help and finding kind of this confidence where you can express your frustrations. So if you can find one, a trusted coworker is nice because they understand what you're doing day to day. If not, maybe finding or creating a peer support group might be helpful. And then prioritizing self-care. So resilient workers tend to optimize their sleep. They actually drink water during the day. They make sure that they take a break and eat. These things seem really simple, but they can really affect how resilient you are. And of course now, especially, limiting news and social media is probably a good thing to do. And making sure that you actually take those breaks. And then finally, recognizing others. So it may seem counterintuitive when you're stressed out, but it actually works to kind of say, hey, like, you're doing a good job, and it makes you feel good that you've said that. And then it kind of creates an atmosphere where people recognize one another. So some interventions that have been tried, and not in dialysis. So mindfulness or stress management programs. There's been cognitive behavioral techniques, workshops, and they've actually had like personal coaches with healthcare workers. Most have short-term effects, so I italicize short-terms, but just not because there's not necessarily long-term effects, but people just haven't looked at it, so we don't know, does this last? And they vary with kind of the duration of the, was it a one-time webinar or was it a 6-week course, and how intense it was. And then the delivery, whether it was in person or digital. I think we all have a million digital trainings that probably we don't spend a lot of time on. And then whether it's an individual or a group intervention. And then I just wanted to distinguish between personal and organizational resilience. So the organizational resilience is the actual organization being able to adapt to and survive disruption. So COVID was the big obvious one, but thinking of hurricanes, things like that, winter storms, while maintaining its core functions, and they can anticipate, prepare for, and respond to change. So the 3 stages of organization resilience are anticipation, so anticipating that this could happen. I don't think anybody was ready for COVID, but we probably should have been. Coping during the event, and then adaptation after the event. And this adaptation then feeds back into that anticipation and the planning. So even with effective interventions, so say we do a mind-body intervention and everybody's like really resilient now, we still have the resilience of the organization. So you still need that in order to have a functioning health system. Organization can be the patient care team, the clinic or hospital, ownership, thinking about dialysis clinics, and administrative levels. This can be very complex, and any breakdown can cause the whole thing to break down. And this is particularly true in dialysis. So this is a complicated figure, but there are a lot of levels that go into how dialysis care is managed. So we have kind of the government, so we have CMS, right? Like they're above all of this. They pay for dialysis, they have reimbursement policies, they have their pay for performance, they oversee the ESRD networks, which also oversee the organizations and clinics. And then there are some state mandates. So in some states there are staffing ratios, things like that, that they have to follow. And then at the organization level, so there's lots of dialysis clinic organizations, some LDOs, some MDOs, a few nonprofit independent. And then at the level of the clinic, so they're dealing with QIP data collection, organizational policies, and then kind of the clinic policies and their culture at the clinic, as well as kind of team dynamics, safety culture, things like that. And then at the level of the individual, we have kind of the dialysis worker and the patient, and there's multiple dialysis workers. Kind of if they're unable to provide optimal care, that can lead to burnout, exhaustion, injury. So, being resilient to that could be very helpful. And all of that stuff, and it feeds back on each other. If you have burnout, you're going to make more mistakes, things like that, and errors that cause patient harm. And then as I mentioned, there's more than one person on the dialysis team, right? So we all have to work together, and it can be difficult because everybody's not always in the same place. They don't have the same expectations. So organizations that have resilient workers, so these are the workers within the organization, so they tend to encourage worker autonomy. So they give leeway on how best to do their tasks. So being as flexible as possible. Recognizing the value of workers. So it includes wages, but also benefits, awards and shout outs, educational opportunities. And showing willingness to change the culture, I think, can be very helpful. Encourage and actually respond to worker feedback. Don't just have a comments box that nobody opens. So encourage and respond to that feedback. And there's no culture of retaliation against workers who complain. So being aware of the problems among the workers can be helpful. And then easier said than done, maintaining adequate staffing. So the more you can do for retention, I think even more than hiring is helpful. And then organizations that are resilient, at the organization level, they tend to prepare for disruptions, so they have contingency plans. They learn from their mistakes, so things like case reviews of errors can help people adapt. And then continually adapting, so you're regularly reviewing your processes, worker satisfaction. It's not a one-time thing and then 3 years pass and things have changed. So, and this is just one example I found one study about resilience, and it was at the VA system level. So they looked at dialysis emergency preparedness for natural disasters. So again, there's the 3 stages. So we have anticipation, which is what they're preparing for, coping, adaptation. But this anticipation is informed by things that have happened. So Hurricanes Sandy, Katrina, Helene, Milton, all taught us what works and doesn't. And then also Winter Storm Uri, which I can't remember where that was. But what they did was they came up with a process flow diagram. And then their system actually overlays power outages, FEMA shelters with the patients. And they can click on, hey, in Hillsborough, Florida, after this hurricane, they don't have any power. And you can click on the vulnerable patients, and the list of patients will come up with their phone number, and you can check on them. So I thought this was a great example of kind of adapting and being resilient. So that was it. I will stand up here so we can go through the questions, but I think we should skip the poll. So what we were going to ask is about personal resilience, but the panel discussion question is related. So what strategies have you or your colleagues used to improve your own personal resilience? And anyone can speak and use the microphone because we're recording. If you can move it around, that'd be great, but I don't know.
Yes, if you can go back one slide, Laura. I just wanted to understand better what you were showing regarding the VA system. If you can go back one slide.
Yes.
Yes, perfect.
Yes, you can ask questions about my slides as well. Sorry. You can ask questions about my slides first. Sorry about that.
Yes. No, but what I wanted to understand better is at the state level and then county level, so who manage that response system? Is it at the level of FEMA? Is it the health department?
It's the VA. So this is the VA. Yeah.
And it's independent.
Yeah, so they get, since they're government, they could get the FEMA data, they can get all that stuff.
But technically, this is a system that can be reproduced, let's say, at the level of the dialysis.
Yes, in theory, yes.
In theory. And in that paper, because I see the reference, it's called nephrology hypertension, correct?
Yep.
So they have not applied that at any of the LDO level or not.
I doubt it, because it just came out this year. So
yes, okay.
I was excited to find anything.
But I think that's a very important referral, because even us as medical directors, and we try to organize and prepare for emergency preparedness, we struggle because there is no template to follow. And we have to create our own list of patients and operate this on a regular basis.
Right.
I think that's extremely useful. Thank you for
Yes. Yeah. Okay. Any other questions before? Sorry, I cut everybody off with questions.
One thing I want to add, coming from California, the fires that we had, and I remember back in 2017 with the North Bay going over the Golden Gate Bridge, up north, and that's where the fire started. It was awful, and you know, my company had a response process in place, and you know, I remember, you know, we had to account for all of our patients, all of our staff, where did they end up, is everybody okay?
Right.
And then had to account for how are we going to get patients dialyzed. And I remember, you know, me being a dietitian and helping the dietitians going through and like, what are the critical patients that really have issues with fluid?
Right.
We really need to hone in on them. And we obviously couldn't dialyze everybody at their normal times that they would. It was just a matter of, can we give them at least, you know, 2 hours, because we had patients for everywhere that would come into one of our clinics up there that was a really big clinic. And we actually even had patients way up north, like 4 hours north.
Right.
Couldn't get any, you know, we got them on a bus, they came down, we dialyzed them, you know, even though they weren't our patients. So, you know, hurricanes, all of that stuff in the East Coast, but we always deal with fires in California.
Right. Yeah, and just all of these things can knock out the water supply, the electric, and just it's just over if you don't have water, right? So yeah, it's good to know where they are. Okay, any other questions on the slides? Yeah.
Okay, so I can speak specifically not to VA, but to hurricane kind of response and how we dealt with it. I lived in Florida for several years, so I was down there for like Harvey, Irma, Maria.
Wow, okay.
So Irma hit me specifically. I was in Central Florida. What we did is, like, every year we had to have all the staff, all the patients, we would give them a letter, a curfew letter, so they would know that they were allowed to be out whenever nobody else was supposed to be. This is, you know, we had all their orders updated, so when we knew ahead of time that the hurricanes were coming, we would make sure we would have them all their orders updated, their cardex, so they could go wherever they needed to get the treatment that they needed. They had their 3-day diet, which, finding out after that hurricane, needed to be extended to more than 5 to 7, because everybody had no power for at least 5 days after. We knew we had shelters, the public shelters, and so we knew which ones would accommodate medical equipment like oxygen and stuff like that. So any of our patients that needed that, we would try to get them signed up ahead of time so they could get there. We knew which ones would accommodate pets and things like that. The day before it was supposed to hit, we brought in every patient, and we had probably 80 to 90 patients at that time. We started early. We ran everybody 2 to 3 hours, depending on their fluid status, and got everybody done. And you know, just reiterated with every patient, please, please, please be careful with your diet and your fluid status, because we don't know when we're going to be able to be back open. I think in the aftermath, we only had 1 or 2 that ended up in the hospital because they were into fluid overload. But the following day, even though the clinic was without power, we were still able to get in, get all the patients' information, because we had, you know, everything printed off. We were able to get hold of every patient. We were able to get hold of every staff member, make sure, you know, who we could with the staff. We were able to get into hotels as appropriate. The company actually did fairly well taking care of staff at that time. The issue became there were so many clinics without power, and they were still dealing with the aftermath of Harvey over in Houston. All the generators were there, so we had none. Oh, no. So it was a week later before they got the generators, and so it was okay. That was something for the company to learn from that perspective.
Yeah, and I think, you know, with hurricanes especially, we tend to think of the coastal areas, but the flooding can occur anywhere. And so, I mean, flooded in Asheville this year, and so, you know, just you wouldn't think of it, but yeah. So everybody has to have some plan in place. So yeah. Okay. Any other before we chat? Okay. So again, so moving into the personal resilience, what strategies have you or your colleagues used to improve your own personal resilience, if any?
Let me answer. Improve? I don't know if I'm in that position to improve myself, because I think I'm there. After 50 years of doing what I've been doing, I've been there, done that, seen it, experienced it. I have a philosophy in life is that there are no problems in life. just challenges and opportunity. And that's what I always live under. And a long time ago, in order to actually not feel stressed in this profession, I stopped looking at it as a job. This is my calling. Dialysis, after 50 years, it's my calling. And that helps me actually endure some of the ups and downs of our industry, is that it's my calling, it's a challenge, and if you look at who we're trying to take care of, think of their issues, how resilient they are. If I were in their shoes, could I be that courageous and resilient? So I use them as a model to actually be resilient.
Yeah, there are some studies out there that have looked at kind of the patient voice in improving resilience in healthcare workers. So that's interesting. Kind of hearing how they deal with it. We should make a little circle, I think.
Very sorry about that. But I think Danilo touched something I was just thinking about before you asked the question. As you were showing the data and talking about resilience and what people can do, I was thinking, going to ask you if you know of any data, not necessarily in the renal sphere or the dialysis sphere, but other field where people look more in detail about resilience, and if there is anything about experience working in the field and being more resilient. Because what I'm hearing from Danilo is that he's been there, done that, he's seen it all, right? He's been in the field for like 50 years. But I'm thinking about the person who's been working in the field for a year, 6 months, 2 years. They don't have much experience. It can be a very stressful environment. And then the question is, how do they deal with it? What can they do to improve the resilience? What advice would you give? This is not necessarily for all.
Okay, thank you.
No, I think how we approach how we bring in technicians into our industry is completely wrong, because of the educational level and what we teach them has nothing to do with resilience and how to cope with job. It's how to put them on and how to take them off.
Right.
That is the focus, and I think we are somewhat, negligent in giving them the tools to actually have resiliency, be able to stay in dialysis for so long, enjoy what they're doing, and actually embrace it as a calling rather than this is a job that I'm going to leave in 3 years, according to that thing. So it's at the very beginning when we bring them in. And I think the larger companies has an obligation to actually concentrate on the emotionality and the resiliency. What's the word I'm looking for? I can't think of the word, but that personal traits that they have to focus on. Not just, here's a needle. Here's how you stick it.
Yeah, I agree. And not just resilience, but we're thinking about like crises and things that happen, but even in the normal dialysis, you lose a lot of patients. You've been chatting with them, you've become friends, and like, how do you deal with the grief? And so.
One thing that this makes me think of, Danny, is this is resilience sort of a trait characteristic of people, or is it more a state, current state, or is it a little bit of both? The other thing that this also reminds me is that we focus so much on tasks and the doing, and not the essence of why we're doing it with our patients and families. So.
Okay, so the first part I can answer. So it's definitely not like a fixed trait. I would say, a personality like Danny's probably is a little bit easier to be resilient. A personality like mine, less so. I'm not as optimistic, but there are ways to get around that. That's what like cognitive behavioral techniques do, is kind of rethink how you approach things. So it's definitely, it's adaptive in addition to resilience being adaptive, and it's coping skills that you learn over time. So I would think older people with more experience are far more likely Like, oh, I've been through something not exactly like this, but like we had a terrible time 10 years ago. We got through it. And,
for me personally, I am very spiritual. I believe, I have a strong belief, and everything is possible through Him, and I'm never disappointed. So that's one of the things that makes me strong, is my strong belief. And not everyone has that strong belief, but they can have that kind of sentiment even though they don't believe in a higher power.
oh, yeah.
It's actually believing in themselves that I am good, I can do these things, I can be resilient, I can face challenges. They're not problems, they're challenges.
Right. Yeah. I mean, the people who haven't dealt with anything are probably 9 years old, right? And, you know, the more you get through life, the more you've dealt with, and it should give you confidence that you've been able to get through that, and you know, learn some coping skills. So, yeah. And there's probably also, like when you mentioned, you know, the older workers probably, or the people who have been in it longer, I shouldn't say older, there's probably some survival bias in that as well. So people who don't kind of develop coping skills probably move on to a less stressful environment. So. It's okay.
It's a lot of mindset. It's, you know, worrying about today's problems is not going to, it's actually going to interfere with today's and tomorrow's peace. Yeah. Whatever's happening now, guess what? Tomorrow's still going to come, so figure it out.
Yeah. And if you make a mistake, something bad happens, you learn from it. Yeah. Like, no one gets through life without mistakes, and so failures. We've all done it. So, anything else on this one?
Come on.
You don't have to talk.
I'm a nurse practitioner, and I've worked in dialysis most of the past 40 years.
Wow. Okay.
So I feel like resilience is not a trait, but we do have personality traits maybe that help us be more resilient. Or I know my mother was a nurse, and she just had a soft heart for the geriatrics. I think I learned that from her. But dialysis, I say it gets in your blood. And if you find that it's not for you early on and you leave, probably don't come back and try it again. A few people do, but I just feel strongly that a lot of people either love it or hate it for the most part. And you have the close attachments to your patients, you have the benefits that you don't see them for a 12-hour shift, but you see them often. Sometimes you feel like you see them more than you see your own family. And if that's not the type of relationship that you can deal with your patients, and we have some residents who come now that I'm in the hospital some days, and they say, I don't want to know my patient. I want them to be out, or I don't want to talk to them. I don't know. I don't want a chronic relationship with them. I don't know how you can do that. Well, then don't go someplace else.
That sounds like hospital medicine, emergency medicine.
But maybe or they say, I want my patient to be knocked out. I want to be an anesthesiologist. But you still need to be able to communicate with them. And the other thing I think I would just say, and this is along the line of what Danny's saying, I took a class many years ago to be a charge nurse. And I feel like if you're in charge that day, try to bring your best attitude and best that. Sometimes we had a technician who, had open heart surgery. She was on the ventilator. I tell my team, she's the closest to death that you can be. We had this go on, we had that go on. But we're all here today. The ones of us that showed up, we're here, we're gonna make the best of it. We can get through today. And you'd be right in there with them. And I think try to bring your best attitude in the worst situation, and hopefully some other day somebody else can do that for you.
Right.
You will not be able to do it every day.
Right. I mean, we kind of expect the patients to do that, so why? Yeah.
Yes.
Like, oh, he's in a cranky mood. Like, well, he's on dialysis, it's going to happen. So, yeah. Okay, great. Any other thoughts on this one? Okay. Okay, we're going to skip that. So what role do you think care team dynamics, so thinking about how everybody works together, plays in the personal resilience of the workers or in the organization? See, nodding. So there is a role.
I think it's huge.
Yes.
I mean, how many?
It's a leading question, yeah.
Yeah, my role, how many times do I get a call from a dietitian? We know that the clinic itself, quote unquote, doesn't really work well together. And, helping them navigate all of the personnel issues that you find in a clinic. And, at times, yes, they've left because center manager, they couldn't deal with them anymore, or, leadership stuff. I think it plays a huge role.
Again, I'm going to harp on how we're doing dialysis. Okay. We have schedules, we have assignments. It tends to give us a silo effect. And when you have a silo effect, this person is doing this, this person is doing that. It's not that we're doing this. I was in the military. And as a military, I had to have a team dynamics. Otherwise, you weren't succeeding. If a buddy was down, you picked him up. There is such a thing as no one gets left behind. I did 2 tours of Vietnam, so I know what that means.
Yes.
So in the resiliency of the organization, we have to change our way of doing things so that we have team relationship. When I first started dialysis, we didn't have automatic blood pressure cuff that you set and you never saw that patient until you took him off because it did the blood pressure frequently. What we used to do is we used to go around as a team. One person would document because we didn't have EMRs. We had paper. And I don't know how many of our staff actually knows how to use pens anymore. But we used to go around as a team, and one person would do the blood pressure, one would assess, excuse me, I'm a technician, I can't use assess. One would look at monitors and look at that and report it to the person that is scribing. We went around as a team. There is not that anymore. So I think to increase our team dynamics for more resiliency, we have to be a cohesive body with the same focus.
Yeah, I would just add to that the really hierarchical nature of the team in dialysis is really problematic and should be interrogated. I know in some of the work we did with our focus groups with PCTs, a lot of them commented that the nephrologists at their center didn't even know their names. So I think that's a real problem when team members don't even know each other.
Right. Yeah.
It's amazing you brought that up because that's exactly what I was going to say.
You're the nephrologist who knows your PCT.
When we did the study, I remember that because that's the experience that I have seen. When I became a nephrologist in the dialysis unit and rounding the PCT, that's how we call the technicians, they were surprised that I was talking to them and realized that I was learning from them because what the patient was not telling me, because the patient didn't remember to tell me, they were telling me. Transportation issue, diet issue, family issue that can affect the way they come to the dialysis unit or not, missing dialysis treatment, etc. It's amazing. And establishing relationship with the whole team, not only the nurse manager, the nurse at the bedside, the PCTs, makes a whole difference in the culture of the clinic. And the patients realize that, and the patients feel that. They feel that we are part of a team, and we work together to improve their care. So they are more open to us also. And I think by doing so, I feel that when I come to round on the dialysis unit, like my once a week for 2-3 hours, and I see the whole shift, I feel that I'm better accepted, let's put it that way, by the whole team than if I come and I don't talk to anybody and I just see the patient and I move on. I miss so much, and I have no clue what's going on if I don't talk to everybody to get a better understanding. Why is this patient shortening their dialysis treatment? They have a reason. It's not because they just want to do that.
Right.
There's a problem.
They're not just trying to irritate you. Yes.
So it's not helpful for me to go tell the patient, hey, it's not good for you to shorten your treatment by half an hour without understanding why this is happening and how we can work as a team to improve the situation. See? So it's a culture issue. So it's a whole team issue, as you pointed out.
Yeah, I remember once when I was, so I'm a PhD scientist, so I'm not in the clinic, but I have rounded with physicians, and they're very different ways of rounding. And just seeing kind of the team around them, and the dietitian would just read the phosphate, and that was it. And he wouldn't ask any questions. And kind of when the patient had an issue they wanted to talk about, they would kind of grab the sleeve of the other person and pull them back. And I felt like the patients didn't think, I don't want to bother them with these things that are for the social worker. It's like, they need to know that stuff. Everybody should be talking about what's going on. So,
I just wanted to add that when I see this question, I think about what I study, which is the work environment, which is a lot of the things that you mentioned, but also management, the relationship with management. Do you feel like your leader is responsive to your concerns? Because if you're working in an environment where you feel like you can't voice your concerns, or you feel like your problems aren't being resolved, that can also impact your resilience, your willingness to stay in this place and turnover as well. And again, just relating back to what many of you have said, relationships with providers and how people interact with each other, and also that recognition that staff gets for their performance, or just feeling valued, is also a part of that work environment that kind of really impacts burnout and resilience amongst dialysis workers.
and I didn't mention in the talk, but the actual built environment is also important. Is the social worker's office like away? Or are they working remotely and people don't know they need to call the social worker, or what they need to call the social worker about? So things like that can also affect it. Like, where do you do your huddles? Are you actually seeing each other during the day?
So, pride has a lot to do with how resilient you could be. And I'll tell you why I hate the word PCT.
Yes, I apologize.
I'm sorry. PCT denotes where assistants and helpers. That's what it says. They're in the hospital, in ER, in med-surg, and they're patient care technicians. They're called patient care technicians. They don't do the invasive procedure or the critical procedures, intensive procedures that we do for dialysis. And that's why every time I hear PCT, it's like somebody putting their fingers on the blackboard, scratching it that way. So, education 1, I am a dialysis therapist. I'm not a patient care technician. I'm a dialysis therapist.
I like that term, actually.
Yes, I do. I don't care what everyone else says. In my organization, we're trying to change it formally that all of our technicians are dialysis therapists. But anyway, as far as pride, I'd rather have pride in the title. There's a title goes a long way. Now,
it does.
He's not a patient care physician.
Right.
He's a nephrologist.
Right.
There's pride in that because he earned it. And I think we earned the title of not being called patient care technician.
Yeah. Agreed. And the example I used in our paper was actually the flight attendants, right? Because steward is like First of all, it was only women. They were just waitresses in the sky, right? And adding the flight attendant, it became like an actual career, and gets a lot more respect now. So it's important. So okay, I don't know where we are with time also.
We have 15 minutes.
Okay, perfect. Okay, yeah, we won't do that. So what resources would you need to optimize your personal worker resilience and or the resilience of your clinic? What do you think is missing? Or is it so much that you bring up the list that rolls out?
I don't think it's so much what's missing, it's what's being bombarded on us.
Okay. Yeah. Or things that could be removed, let's say that.
I agree that it is what's bombarded. Things are always added, and it's really seldom is anything taken away. The other thing is, it's out of the control of the team.
Yeah.
But I think as a manager and as a team, you do have to form your team, and whether that's that they say form a storm and then you get along. The workforce, you need quality applicants, and plenty of applicants that you have some choice of who fits and matches with your team, which I think is just something that's really difficult right now. And I don't know, I'm finding it's not just true in healthcare, but I felt like it was particularly true in healthcare since COVID. People were scared to death. A lot of nurses got out of healthcare and they'll never come back. So, and I'm right there with you. Nurse practitioners, we don't have any kind of title. We just really are addressed by our first name, which is fine too.
Right. But nurse practitioners specialize and they don't have specialized names. Yeah.
We don't have a title.
I'll make
So it sounds like staff is one of the resources.
I'm getting a little jealous about what clinic that we know that our staff are tired and gets tired. So in our staff lounge, we have 3 recliners and 1 sofa.
Ooh, nice.
That helps with it.
Yeah, I mean, it's a small thing, but yeah.
It is.
Yeah.
You know, they asked for it. We gave it to them.
Yeah, I mean, I'm sure you're walking around all day. How many miles do you walk in a day? Yeah. Yeah, we need a different arrangement here.
To your point about employee retention, I think it's really critical that employees feel like their employer is invested in them. So giving people opportunity to come to MKS spring clinical meetings or get additional training is just making you feel good about your work and your opportunities.
Careful. Any other? Anything like snacks? Small things?
It has to be more than just a casual pizza party.
Yes, the pizza party, yeah.
My clinic has a massage, just a simple massage chair that they can sit in. It doesn't recline and all that, but unless you can get a back massage. But I do think sometimes, the nephrologists and us providers that maybe aren't there every day, maybe if we can treat them once in a while, instead of always thinking it has to be the company or out of the company budget, maybe try things like that, that not only we are part of the team that way, and we value, it does make a lot of difference to the staff. Many of them know me from being a nurse and a facility administrator, but the newer, dialysis therapists. You know, they do appreciate you talking with them, and I always try to not be offensive to reporting something to the dietitian or to the social worker, because just as the doctor said, they'll tell me something completely different than what they're going to tell the social worker, what they're going to tell my physician collaborator when he rounds the next week. At first, you're almost kind of embarrassed. Did I miss something as a new nurse practitioner in your role? But I was, and but then you think about it, you realize it could be 5 minutes later. They'll tell, and probably they're going to tell the person who takes care of them, their therapist is their therapist, and they're going to know a lot of things. You of course want to be careful for them not to feel like you're breaking confidentiality, but you also have a responsibility to report, as we all know. So I do think doing things for the staff makes a big difference, and it has to have some variety, not like, oh, we're going to throw pizza on the table.
I feel like the pizza parties need to end. That's been, I feel like every healthcare worker has complained about the pizza parties.
In line with that, I've stayed in this business this long. The work is not that difficult. It is tedious, but it's not difficult. Yeah. When people say it's not brain surgery, well, sometimes it can feel like it. But the work is not what actually deters from being resilient and having tenureship. It's being challenged. It's being given some value of the things that you're doing, being engaged. Those are the kind of things that actually build up your character and resiliency. And I don't think we do that enough in our industry. In my facility, what we've done is we created that ladder some 12, 15 years ago, where we engage technicians to do above and beyond outside the put on and take off. They have projects and they love it. Again, it's more work, but it's not more work. It's an investment in yourself. And I think that's what we have to instill into our staff, into our peers, into our staff.
And I think I was going to call up Bernard, but he's talking.
Oh, I did? Well, technician, I didn't say he.
So Bernard, I was going to ask you about the QA projects that you have technicians, therapists, whatever you want to use, involved in. I know you mentioned that you get the technicians and or therapists involved in QA projects, and they're in charge of
That goes along, very much so, because what we do, not only we have to make them value what they do, because they're the frontline workers with those patients, and I value what they do very much so. To go back on what Danny was saying is that we do need to call them what they are, and they are truly therapists. I think we need to make an effort in our industry to change that term formally and make it recognized. I think that will go a long way. But also value the work they do and encourage them to be more involved in the patient care, because they can. And again, they're on the front line. So we do a lot of QI projects where we look at patient adequacy, where we look at vascular access, where we look at nutrition, etc. And they are educated. So the therapist is educated specifically a bit more than the other therapists for a specific topic. For example, the one that I like a lot, which has been very successful, is the adequacy. So they know to look every month at the result of the adequacy test and to know who's passing that test and who's not passing that test. And those that are not passing that test, to understand why they are not passing the result they should have. Is it because of the time? Is it the dialyzer? Is it the blood flow, etc.? And then to bring it to our core team when we meet and discuss it. And they take the lead to not only flag the problem, even before I start my monthly round, that's already identified, but also importantly, to bring solutions to the problem and to repeat the test and make sure it happens. So it is extremely helpful. Ultimately, it helps the patients. You know, it helps the outcomes that we're looking for. And this is driven mostly by those dialysis therapies, very importantly.
So I'm actually wondering,
that's
like,
what
how
we
many
provide.
people like involve them in patient care conferences at their clinic? Like, have you seen that at your clinics, or? So Danny and Bernard.
We have patients involved.
Well, I mean, the therapists.
Yes, it happens, but it doesn't happen regularly
Okay.
because the therapists are not always available, and the ones that want to participate
Yeah,
are not
'cause
necessarily there when we do it.
Because I'm currently working on a pilot to include them.
Yeah.
Just the amount of pushback I've gotten for like, oh, they can't be off
But
the
I
floor.
think someone-
Yeah.
If someone values what they do, you know, beyond being a therapist or a nephrologist or whoever you are, whatever field you're working on, if you value what you do, you become more resilient. And
Yes.
we as leaders in the field, we need to also make sure that we value the work that other people of that team do. Because we work as a team and we can be successful by ourselves.
Yeah.
You know?
Okay, we have 3 minutes, so.
As far as a clinical ladder for technicians, it's a team relationship because in order to actually climb that ladder, they have to have a nurse advocate. And so the nurse advocate becomes that technician's partner in his journey with doing the quality improvement project. So it's not just the technician, it's the team, and we are a team. Therapist.
We'll get a change someday. So any other thoughts? I don't want to bring up a new question with only 2 minutes left. Any questions that you guys have that are not part of our panel or comments? Okay. All right. I think that's it. All right. Thank you so much for coming. I know it's the end.